Hello and welcome to Chagpar MD. I'm Dr. Anise Chagpar and I am back this week with a very special guest, one of my good friends, Tony Nguyen. Now, you met him last week when we talked about lessons learned from the story of his mom who was diagnosed with stage 4 ovarian cancer. But Tony is a breast surgeon down in Florida. Florida, a place where many of our more, shall we say, mature patients reside. And I thought that it would be a good thing for us to talk to him about some of the special considerations we have for dealing with breast cancer in the elderly. So, what do you say? Let's get started. Hi, Tony. Welcome back.
Hi, Anise. Thanks for having me back. Pleasure to be here.
So, Tony, when we think about breast cancer, we know that the incidence of breast cancer increases as one gets older. And with you down in Florida, I know if I'm going to retire, I would love to retire in a place like that, where you can certainly see a lot of more mature patients. So talk to us a little bit about the considerations in the elderly patients. I mean, do you treat breast cancer the same as in a patient who might be 40 or 50 when that patient is 70 or 80?
Well, thanks, Anise. Great question, and thank you for that introduction. So yes, disclaimer, I currently live and work in Florida. Another disclaimer is I'm relatively new to Florida. It's only been my 4th year here in Florida. And yes, I do treat and see a lot of patients in their late 60s to my oldest patient so far now is 101 years old. Very healthy lady, by the way. So we do have a very special population here in Florida of a lot of retirees. Our model down here is live where you go to vacation. So people tend to be quite happy with the nice sunshine down here. Back to your question about how to treat breast cancer in a 40-year-old versus someone per se in their 70s. And no, I definitely don't treat breast cancer the same way. My conversations, although they're very, very long and sometimes much longer in the older population, as you say, are much different in different populations. Breast cancer, as we all know now, is not one disease. It's several different diseases, different subtypes, different methods of spread, different methods of recurrence, different treatments, different recommendations as far as radiation or long-term treatment is considered. And the other difference is age. Younger people tend to have more aggressive disease. They also have more to lose. They have if you extend their life expectancy out, they have potentially 40 to 50 years left of life to live. And what I tell a lot of my younger patients is the worst thing about you is that you're too young, and that you have a lot of years to just sit around and wait for this cancer to come back if we don't treat this correctly the first time. In the older population, now, older populations tend to be a little bit more diverse. You can have somebody who's not in the best of health, who's maybe in their late 60s. They have a failing heart. They could have Alzheimer's. They could have a various of other diseases or conditions that may not live until they're 80. And you have a lot of patients that are like my 101 years old. She goes out and she lives alone and she works and she still volunteers. So there's a huge diversity in terms of what you would call older. So I don't treat age per se. I treat the patient and how functional they are and what are their goals and what are their expectations, because not everybody is the same, no matter what age you are. But especially in the older population, I find that their goals are also very diverse compared to the 40-year-old who's, typically a working mother, caretaker for a parent or two. And so the older population sometimes don't have as much, medical reserve, and they have a little bit more conditions that impact their lifestyle and impact their life expectancy. So in the older population, the reverse is true. A lot of these cancers are indolent or low-grade cancers that typically what we find is that these cancers won't typically be the cause of their mortality, especially when they're caught early. They will die of something else.
And so let's kind of take that whole spectrum of management of breast cancer from the very beginning to the end and see what are kind of the nuances when we're thinking about the elderly population. So the first is screening. When we think about screening, and there are a whole bunch of different guidelines out there with regards to breast cancer screening, and I'll link to a video here that we did on breast cancer screening. But as you can see in that video, when to stop doing your mammograms really varies. Some say you should stop at 70, some say 75, some say when you've got 10 years of life expectancy left, as though we all have a crystal ball. So, Tony, what do you tell your patients in terms of screening?
Gosh, that's a very hard question, a very complex one. We could talk for hours and hours about when to stop screening, because it's not just a scientific question. It's a personal question. It's a social question. So, what I talk to patients, and it's oftentimes a 20 to 30-minute discussion about what's the benefits of screening, some of the data behind it, and when should they stop. Some patients want to get screened until they can no longer go get screening. Some patients really have the mentality of, look, I don't really want anything done to me, even if I find something. So I'm going to stop screening. And I think that's a fair answer.
Totally.
I typically still use if you seem healthy and feel healthy, and we kind of both feel like you got 10 more years in you, I think it's reasonable to use that criteria, because that's something that patients can relate to. Again, if I tell a 70-year-old patient who's extremely healthy, still runs her business, still plays golf, still travels, that, yeah, we're going to stop screening because, if we find something, we're not going to treat it. That doesn't make any sense to her. And similarly, if you tell a patient that doesn't want anything done to her because she has advanced Alzheimer's at the age of 70, just continue screening, that doesn't also make sense either. So I think it's a very personal decision and involves a complex discussion. And oftentimes, us doctors are very, very busy, and we just don't have that time in us to have that complex discussion. And that discussion should happen probably every year, just to revisit the goals and health of that patient.
Yeah, I agree. I take the same approach. If you are healthy enough, no matter what your age, that, if you find a little pre-cancer and you will want something done about it because you've got the rest of your life to live, then absolutely get screened. But even if you're younger, if you've got so many other medical or other comorbidities that, finding a little cancer would be the least of your worries and you wouldn't want to pursue any treatment of that, then why bother opening Pandora's box? So
Right.
I am right there with you. So then the next question is, what about surgery? So surgery, I always break it into two kind of buckets. There's the surgery for the breast cancer in the breast itself, and then there's the surgery for the lymph nodes. And, historically, the kind of cookie cutter answer is, well, we need to do something in the breast, either a lumpectomy or a mastectomy, and we need to check the lymph nodes. Is that the standard that you apply to all of your elderly patients, or is there some nuance that you apply there as well?
Great question again, and definitely it's a personal and long and difficult discussion with a lot of my elderly patients. I always say that it's actually quicker to have a breast cancer talk with your younger patients or with your middle-aged patients than with an elderly patient, because we know the standard of care of breast cancer therapy, surgery and chemo and radiation. And so that's really the majority of my talk to your younger patient. In the older patient, I also talk to them about the standard of care. And then the second half of my talk is why maybe we shouldn't do what is considered the standard of care because of a lot of data that has emerged in the last 5 to 20 years, looking at, does the standard of care apply to older patients? And so, much as you said, we deal with the breast cancer and we check the lymph nodes due to staging and local regional control to reduce the recurrences in that area. In the older population, especially when they have a 5 millimeter or a 8 millimeter cancer that's a grade 1 out of grade 3, not very aggressive cancer. These are the patients that I really have a difficult time with sometimes, because I tell them, look, this is the standard of care for probably 100 years. We were taking off the entire breast, take off all your lymph nodes, give you really bad lymphedema and pain in the arm. And only recently did we find that we didn't have to do as much of those, even in the younger population. And then in the older population, a lot of us still treat the same way as we would treat a 50-year-old. And is that the right thing to do? Because now we have ample evidence to kind of risk stratify people, meaning that we can sort of predict who needs it and who doesn't need it. And every therapeutics has its risks and side effects, right? Surgery has pain, bleeding, infections, scar tissue issues, and radiation has a whole host of side effects. A lot of them are manageable, but again, if you didn't need it, the side effects are unwanted. And so my conversations with older patients tend to be a little bit more complex, actually, because I discuss with them what we can sort of pick off as far as not do, and they would still get the same oncological outcome.
Yeah. So it's so interesting because in 2016, the Society of Surgical Oncology, the SSO, put out a choosing wisely guideline that said that, sentinel lymph node biopsy, or checking those lymph nodes, is not something that should be routine in patients over the age of 70 who have otherwise, hormone receptor positive early breast cancers. My sense is, though, that many of us still do the sentinel node biopsy, much because of what you were saying earlier, which is these patients are otherwise really healthy. And there is this general sense that 70 today is not what 70 used to be. And so I'm always interested in kind of that variation, as well as the fact that sometimes the medical oncologists and the radiation oncologists want that information too, but you're quite right. There may not be a whole lot of data that it really is going to impact their care. So what do you do after that? I mean, are your patients who are older than 70, in terms of medical management, how do your medical oncologists kind of approach the whole scenario of chemotherapy in the elderly?
Yeah, so I think you've hit the nail on the head on several of those points. One of the things that is difficult sometimes for us surgeons and doctors to do with new data is we can be uncomfortable accepting of a recommendation or new data to not do something we're used to doing. Mm-hmm. As much as I hate to say it, sometimes a hammer likes to hit a nail, right? And so we do this for many of our patients for a number of years. And then, after reviewing some of the data, a lot of the expert societies got together, and like you said, the Choosing Wisely campaign came together and looked at that and did that recommendation. And so it still is uncomfortable for doctors to say, well, I'm going to treat you differently because you just hit 70. And that's just where the recommendations tell me to do. Also, things like sentinel lymph node biopsy has long considered been not as morbid. It's not of a big surgery. It's just a little incision. We take out a couple lymph nodes. We get more information. And so a couple of factors, I think, still lead a lot of us doctors, surgeons, breast surgeons even, into still doing them despite lack of evidence that they benefit these patients. As far as the medical oncology and radiation oncology, well, yeah, I think you can always get more information, but will that more information lead to better survival, better or lower rates of recurrence? And in a lot of this, we just don't have the data. One thing I will say though, we kind of left out is that a lot of the clinical trials that looked at some of the benefit of these surgeries, older patients are not well represented in these trials. And so, uh, we need to have a lot more trials looking at specifically the age groups that we're treating, not just the age, but their health, their comorbidity score, what has benefit, and we need to better decide which patients we will offer these so-called less morbid surgeries for them. And so I think, in a cancer group, whether you're at a large academic center or a small medical group or a solo practitioner who partners up with another doctor down the line, you got to come together and review the data and create a working algorithm to somehow apply to a large number of your patients, a large population of your patients, so you could have a cohesive discussion where you're not saying one thing, the medical oncologist is saying something different, and the radiation oncologist is saying something very different. And so that confuses patients and referring doctors quite a bit. And so a lot of old habits sort of need to die out, and a lot of new adoption strategies need to happen, and that part is coming together and discussing it as a team to have a little bit more unified message.
Yeah, I think that that's so critical in this whole multidisciplinary era of really thinking about how do we manage patients, and coming together and kind of having some general rubrics of how we approach these issues, albeit that they can always be tweaked to an individual patient. So in terms of medical oncology, many patients, as you pointed out, in this older population are hormone receptor positive, and we know that they benefit from endocrine therapy. How often do the medical oncologists at your institution use other genomic tests, particularly in the elderly, to decide whether or not chemotherapy is of benefit? Or do they kind of say, look, you're 70 years of age or greater, you've got a tumor that's hormone receptor positive. I don't really think that even if you had a high recurrence score, for example, and for those who don't know what a recurrence score is, I'll link you to a video where we talked to Lajos Pustai about management of early breast cancer here. But how often do they actually use something like a recurrence score or a mammoprint or something like that to kind of guide chemotherapy decisions? Or have people really kind of gotten into the sense of endocrine therapy is really where it's at for patients over the age of 70?
Yeah, no, another great question. So historically, patients who had a tumor size of 1 centimeter or over got chemo. That's how it was. It was much easier back then when you kind of did the, what I tell patients, what we do is the eyeball test. Yeah, your tumor is a little bigger, your grade's a little higher, you're a little younger, so yeah, you'll get chemo. So we sort of did a little bit of an eyeball test to determine that. These days, as you mentioned, we have real level 1 evidence of genomic testing, looking at specific genes within the tumor to determine a recurrence score or a high risk score, or the likelihood that a cancer, no matter if it's the size of a dime or the size of a $50, will have a likelihood of coming back as a local recurrence or as distant recurrence. And so it's been a challenge, I think, at a lot of institutions, and ours is not an exception to that, to somehow incorporate the clinical data that we get, again, the age, the grade, the size of the tumor, lymph node status, in combination with a test that, we don't really have a good grasp on. We know that it's level 1 evidence. We know that a lot of research and data and long-term follow-up is included in that test, but how do we balance the clinical data with the genomic data and put it all together, and then add in the patient's health, age, and comorbidity, and then also add in their goals and wishes, because cancer, and especially breast cancer, is a shared decision-making. Some patients are okay with a 15% recurrence risk. Other patients want it all the way down to less than 1% if you can get it. And so you got to have to talk to the patient individually. At our institution, we've come a long way. We've evolved a little bit every few months, and we come together to discuss it as best as we can. We're trying to get rid of our old habits, our old traditions, and I think now we're using a combination of the clinical data plus the genomic data plus what the patient really has their goals and wishes. So I think it's kind of like a three-prong consideration when you're just offering chemotherapy to these patients. So we don't do genomic testing on every single patient with early breast cancer, but we generally do it on patients above 1 centimeter. The NCCN guidelines recommend above 5 millimeters, but and in patients with high risk features like a grade 3, a lower morbidity index, and the patient is acceptable with chemo, then we'll also test that patient. But generally, we combine a lot of clinical data to the genomic data.
Right. I mean, it doesn't seem to make sense to do the test if patients have already decided that they're not doing chemo.
Right.
Or if you've decided that they really physiologically can't tolerate chemo, which brings me to the question of, how often in your institution is a geriatric risk assessment done prior to chemotherapy or prior to surgery? I mean, some people have talked about doing these assessments to really look at fitness of the elderly patients. And I'm not sure how much that has really taken off in terms of actual clinical practice.
Yeah, again, excellent question. We've been talking about this probably for over 5 years now. There's enormous data out there of geriatric oncologic treatment. A couple of giants in the field have really published a lot on this, and there's a lot of risk scores and calculators out there. I'll be honest, I mean, we haven't done a great job as far as assessing for surgery, because most of our surgeries are low risk or low morbid procedures if they're just consisting of lumpectomies. There's no surgeries that are free from risk, obviously. As far as chemotherapy, we do have a risk assessment or a geriatric assessment on each individual patient to assess whether they will have a likelihood of completing the chemotherapy, what kind of resources are available to them should they run into side effects or issues at home, because most patients on chemo will have some issues at some point in time. Nobody escapes chemo, issue free. But I think there's a large potential area to improve everywhere, really. I know in the abdominal or GI surgery arena, the data is emerging explosively regarding the prehabilitation of patients and the post-rehabilitation of patients to improve on 30-day morbidity and mortality outcomes. And I think that's, we can definitely learn a lot from those folks and our colleagues.
Yeah. And I think really taking the whole patient situation into account, their home situation, their social situation, really does make a difference. And finally, the last kind of element is radiation, where we actually do have a couple of trials that have looked at radiation therapy in the elderly. How much has your institution really adopted those data? And don't worry, everyone, I'll leave you the links to the trials in the box below.
Yeah, no, again, this is what makes breast surgery discussions fun to some extent, and also very complex when you're talking to specific patient populations, such as the older population, and trying to discuss whether radiation treatment, which is still the standard of care in your average breast cancer patients undergoing a lumpectomy, and whether we should omit radiation treatments based on their age and their size of their tumor and so on and so forth. And so our institution really adopted the Choosing Wisely campaign aggressively, because we have such a huge population here of older patients. A majority of our patients are older than 70. And so we had to, out of public responsibility, look at the data aggressively and look at where and how they can apply to our patients. As you mentioned, there is level 1 evidence, and maybe a little older evidence, but level 1 evidence nonetheless from trials such as the CALGB 9343 and the Prime 2 trials. These are randomized patients, whether or not they had axillary surgery for early stage breast cancer, and the early category is a little bit different, depends on how you categorize it, but less than 2 or 3 centimeters or grade 1 or grade 2. And this is what the majority of our older population patients are diagnosed with. They're not diagnosed necessarily with, the majority of them are not diagnosed with metastatic cancer or advanced cancer. The vast majority are diagnosed with earlier stage 1 breast cancer. So we do apply the emission of radiation to a large majority of these patients. And there is some benefit for the radiation. It's a lower recurrence in 10 years. But what I tell patients is, even in 10 years, you're at 90% chance of not getting a cancer back, even if we don't do radiation on you. So, a lot of patients opt to not have radiation because radiation can have certain side effects as well.
Yeah. And so my last question is, it sounds like the approach really in the elderly is really very tailored, and moving towards less and less aggressive therapy, in part because they tend to have more indolent disease. They have a shorter number of years of life left, and there's toxicity associated with therapy. So my final question is, when we talk about this, quote, de-escalation of therapy, how responsive do you find patients are? Are patients like, woohoo, less therapy? Or does it give them a little bit of trepidation about, like, why are you treating me with less aggressively than you would if I was 30 years younger?
Well, absolutely. And the answer is both of those. You have your mixture of patients, right? No patients are the same. Some patients come in and they say, look, I'm 84. Do the very least possible to me. Or I'm 84, don't do anything to me. Or I'm 90, take that cancer out. So again, a lot of it is talking with your patients, finding out their goals and wishes, having that in-depth and complex discussion with them. And a lot of patients will understand the data if you present it in a way that you can kind of simplify the end results, meaning that I tell patients, look, you probably won't die from breast cancer, no matter what we do to you. So it depends on whether you have a lot of anxiety about that 2 to 10% risk of having the cancer come back. But look at it this way. Again, you're 90% likelihood that you won't have the cancer come back, and you're 99% likely that you won't die from this, no matter what we do. So it depends on how you explain it to them. And I find that patients are so diverse that I can't give a one-word or one-sentence answer, because every patient is a new journey for me. And I take the initial time to figure out what they want and what sparks them, what motivates them, what their long-term outlook is, and again, what their overall health status is, and what kind of support they have at home.
Yeah, I think that's so right. I think every patient is their own unique individual, and together with their doctor are going to decide what's best for them, hopefully in keeping in mind all of the latest evidence that comes out all the time. Tony, thank you so much for being my guest here today on CHAGPAR MD. I hope all of you learned something new about treatment of breast cancer in the elderly. I hope you found this video helpful, and I hope that you will like, share, and subscribe. If there are other topics that you would like covered, please let us know. We would be happy to oblige. Until next week, this is Dr. Anise CHAGPAR wishing you all a safe and healthy week.